There's a national conversation going on regarding the price and affordability of drugs. Concerns for value and benefits of medications are challenged by the increasing price of the medications, including the cost of care for myeloma. With the availability of new drugs, there is an unprecedented improvement in the overall survival, progression-free survival of patients with myeloma. Also, quality of life is improving. With our panel of experts, we will discuss the direct benefits of patients and society and the associated expenses with the new treatments. I'm Dr. Ola Landgren. I'm Professor of Medicine and Chief of Myeloma Service at Memorial Sloan Kettering Cancer Center in New York. Joining me today on this distinguished panel are Dr. John Fox, formerly Associate Chief Medical Officer at Priority Health, currently Vice President of Clinical Transformation and Value at Spectrum Health, and Associate Professor of Medicine at Michigan State University College of Human Medicine in Grand Rapids, Michigan. And Dr. Sundar Jagannath, Professor of Medicine and Chief of the Myeloma Program at Tisch Cancer Institute at the Icahn School of Medicine at Mount Sinai Hospital in New York, New York. Thank you for joining us. Let's begin. So we're going to talk about, to begin, newly diagnosed patients with multiple myeloma. We know there are a lot of options to treat patients. So I was going to start asking you, Sundar, what's your personal preference when it comes to backbone? Are you using immunomodulatory drugs? Are you using proteasome inhibitors? Or using monoclonal antibodies? Or do you have anything else you use as your backbone?
Well, let's define what a backbone is. You are starting out with drugs which could be continued, on which you can build on with the other drugs in combination. Now, there are three classes of drugs which can be made into a backbone. One is the immunomodulatory molecule, and you have the proteasome inhibitor. The glucocorticoids have always been one of the workhorse for the treatment of myeloma, so that could be one of the other backbone. So when you say a backbone, that drug should be important for the management of the disease in terms of its response, and also it should be able to be combined without loss of efficacy and additional toxicity. So in this regard, we have several drugs in myeloma which could be combined effectively and could be in the backbone. So proteasome inhibitor, immunomodulatory molecule, glucocorticoids have been the workhorse. And then alkylating agents have come in when it can substitute for lenalidomide or immunomodulatory molecule. And now you have a new class of drug coming in is the monoclonal antibody, such as anti-CD38 monoclonal antibody daratumumab. Right. So all these drugs could be combined effectively at their full dose with their full efficacy without adding toxicity. So this is what is the playing field now.
So John, from a payer perspective, what's your perspective on this?
Well, you know, because you treat patients, that this field is exploding not only with the number of agents, but also the combination of agents that exist. And our ability as payers to keep up with that is very limited. There are very few oncologists employed at health plans today. So what we follow, and most health plans follow, is the NCCN guidelines. And those are rapidly changing too as we get new drugs and new combinations. Fundamentally, though, if the NCCN lists a therapy as a Category 1 or Category 2A, it's generally going to be covered.
So in my practice, I also see a lot of patients I treat every week, high numbers. I would use the proteasome inhibitors, the immunomodulatory drugs, and the steroids as my primary backbone if I look backwards and I look where I am right now. But I also agree with what you said, Sundar, that adding the antibodies going forward is probably going to be part of the backbone. And of course, there are patients that cannot tolerate all these drugs, so then we are considering taking out some of the drugs. And there are also instances where maybe using alkylators over IMiDs is appropriate, for example, for kidney failure or things like that. So I think we have very similar perspective. And just putting it in context, some years back, there were some groups here in the United States that argued that you could use maybe only 2 drugs as the backbone for what was referred to as the standard risk patients. But that seems to have changed. Most groups are now arguing in the same direction, that having multiple drugs is the backbone. Do you share that perspective?
Well, I think it's a good segue, the way I look at multiple myeloma as a disease. The good news is the depth of understanding of the disease is improved with whole genome sequencing, exon sequencing, RNA sequencing, CyTOF, so many things are there. So not only we are learning that more about the tumor cells, but we are also learning about the microenvironment. All of that has shown that multiple myeloma, by the time it develops from MGUS to smoldering to multiple myeloma, there have been a lot of subclones have developed in the patient's body. So, and there could be some genetic mutation in one subclone which is not present in the other. So under that scenario, what has happened is we also know that every time a new drug has been introduced, this is well documented, especially in Europe, population statistics as well as in the SEER, as new drugs have come in and implemented for the treatment of myeloma, the life expectancy of myeloma patients have improved. And I would actually dare say that some patients are being cured with these number of new drugs that have been available. Not everybody, but a small proportion, but this proportion will continue to improve. If we use that as the backdrop, that in biology, multiple myeloma is multiple clones in the patient, there is a difference between one patient to another, that we call as heterogeneity, but there is also intra-patient tumoral heterogeneity. When we do PET-CT, the lesion in the rib is slightly different from a lesion in the hip. All of that would say that as you add more drugs in combination, you are able to address different segments or the clones of the myeloma, and you are able to get deeper remission. So just like our understanding of the biology is improving, also our ability to understand the depth of response has also improved. So we have minimal residual disease detection, 1 in 100,000 cells consistently by flow cytometry, or sometimes even 1 in a million tumor cell residing in the patient body. So that is also helping us whether we have done a good job, whether we got rid of the cancer, do we expect this patient will do well for a longer period of time, all of this also coming. So right now we are in a watershed or crossroads. So for people from outside looking into the field of myeloma, they may look like, oh my God, there are new drugs and so many combinations, where it is leading to. My perspective, it is leading overall in the good direction, finding cure for myeloma. And it is a rewarding time as a physician for me. And it is a good news for patients who are being diagnosed with myeloma at this time. With that as a backdrop, I think, of course, I'm here to talk to you about all the other aspect, day to day, how to care for the patient.